Good morning. I'd like to introduce Sachin, who's a rising star in FNU urology, a consultant urologist for the last 3.5 years at Guy's Hospital in FNU urology, and he's going to be my co-discussant today of poster session 5, which is mostly on male and female incontinence, but some complex urinary reconstruction. Hi, Sachin.
Hi, Tamsin. Thanks very much. It's a pleasure to be here with you. Everyone knows you as Tamsin Greenwell, a consultant urologist and specialist in female and functional urology at UCH in London.
Fantastic. Without further ado, if we go to the first poster, which is a big cohort of men who've had radical prostatectomy for prostate cancer, over 5,000 men, and they've all had PROMs done, the EPIC 26, and they've correlated patient satisfaction with the urinary incontinence outcomes. So good urinary continence outcomes are a score greater than 75 and bad a score under 50. And what they've shown is a significant number of men have bad continence outcomes, and that's highly correlated with poor patient satisfaction. However, I think the truly shocking thing and interesting thing about this poster is that only 2.7% of men had incontinence surgery. And a lot more men with poor continence scores, and even those with continence scores of 0, which is the worst possible score, didn't go on to have further surgery. What do you think about that?
Yeah, I think it's really interesting data. It's a big data set, but I think it highlights probably what we see in that men. It's a really small number of men that actually go on to have surgery. So it'd be interesting to know what the barriers are, why men don't either get offered the surgery or aren't seeking help for some reason. Is it kind of stigma thing, or are they just not being kind of redirected to the right services at the right time? What do you think?
Well, I think we've all set up, I think, in the big cancer centres, some surviving prostate cancer clinics to look at ED and to look at incontinence. Yeah. But I'm not so sure that all men are making it to that. And maybe it's time to have continence at the forefront of their preoperative counselling and to say, you know, look, here we are. This is what we do. It's not as big as having a radical prostatectomy, a sling or a sphincter. And if you have problems after 6 months, then do make sure you come and see us. Maybe some face-to-face out there patient advertising. Maybe the companies need to sort of get their products out there on the television. Maybe they're not as aware as they should be, yeah.
Because because a lot of men, when they do come, they kind of say, oh, well, I don't really want more surgery. They probably assume that it's like the radical prostatectomy, and I agree. They probably need to just be educated that it's completely different in terms of the kind of size of the surgery.
And I would say to the cancer surgeons, just, you know, it's a key factor in satisfaction with your surgery afterwards. You've hopefully got rid of their cancer. Send them to us, and hopefully we can make them feel a bit better about their lives as well.
Yeah, absolutely. I think it massively improves their satisfaction.
Let's move on then.
Okay, great. So the next abstract is actually it's a really nice kind of cohort study. It's a retrospective review of data of 5 years of using the ATOMS procedure for post-prostatectomy incontinence. So they reviewed here 70 men with post-prostatectomy incontinence, and their report actually pretty good dry rates of 73% completely dry at 6 months, and 77% after adjustments, they say completely dry. So I think for a proportion of men who a significant number have already had previous surgery as well, they seem to be pretty impressive. The only thing that obviously they've given 5-year experience, and we spoke to the authors. So the median follow-up here is 3 years. So I guess still relatively short term. And on average, patients needed 2 adjustments to get to that level. But my experience of ATOMS is not great, to be honest. But looking at the literature, it seems to be that the results maybe slightly higher than the general studies in the literature. What do you have you had any experience of using this?
We've been sent a few from various centres with problems such as urethral erosion, chronic pain, persistent incontinence. I don't really like them, especially the idea of using them post-radiotherapy. I really think slings post-radiotherapy are not a good idea. You can take a bad situation and make it worse. It's probably better to think about artificial urinary sphincter. What do you think?
Yeah, well, so I mean, looking at this data as well, I guess it kind of fits because the poorer outcomes are those who have had radiotherapy. So I agree with you. I wouldn't, based on my experience, I wouldn't normally consider a sling in that group. But I guess the question is whether this, I sort of saw this as a in between a sling and a sphincter, but it seems like even in the radiotherapy patients, it doesn't have a great success rate.
But it has to be said that they're very respectable results, and there are a group of men who don't want a sphincter. They feel it's too complicated. I think in the man who is not post-radiotherapy, who's just had a radical prostatectomy, who's really quite wet, who you would have before steered them towards a sphincter. If you have competence in this technique, then it doesn't seem unreasonable. The appeal is that you can modify it. You can refill the balloon and increase your degree of obstruction. So that's
it'll be good to know on this what the baseline severity generally was, because I know a lot of them failed bulking and a few failed a sling. So I guess you would assume that they're on the milder side, but yeah, it'd be good to know what the severity is and who did well and who did poorly based on that.
Oh, well, fantastic. Shall we move on to the next?
Yep.
So urorectal fistula, we're seeing more of nowadays as a consequence of radical prostatectomy followed by radical radiotherapy. And Professor Mundy's group at UCLH have got quite a big series and have published widely on their fistulas. However, Crohn's disease urorectal fistulas are rarer and actually have been previously thought to be almost impossible to treat. So his group have put together 13 men over 10 years, and they've divided it into 2 groups, an early series and a later series, and there are much better success rates in terms of cure of urorectal fistula in the later series, and that seems to be mainly related to the use of immunomodifiers. And what the group are advocating are urinary diversion with a suprapubic, colorectal diversion with an ileostomy or a colostomy, then the use of immunomodifiers, and then repair of the fistula, and finally reversal. So it's definitely a multi-stage procedure, but in the latter part of their series, they're reporting 65% cure rates, which is really very satisfactory, I think, in this poor group.
Yeah, I think it agrees. It's a complex group, isn't it? And I guess needs multidisciplinary input. And all these patients have flaps. I assume they consider flaps to the defects. But in terms of the immunotherapies, is that, I assume all patients would get the immunotherapy?
Yes.
And so they, because they report here that 8 out of 13 were successful without needing a fecal diversion.
Yes.
So I just wonder how they decide who, because then at the end they conclude that they recommend everyone has a fecal diversion. I just wonder if there's any patients they can kind of predict beforehand that may be successful without needing that, or whether they just think that.
Yeah, but because it's such a poor outlook, I suppose what you'd want to do is to talk to the man sitting or woman sitting in front of you and say, well, the best results are if we do double diversion, then treat you, and then undivert you. Some of them we get away with not doing a fecal diversion, and then it really has to go along with the patients and the gastroenterologist's viewpoint of how severe their disease is. But it's, I mean, 13 over 10 years is a very small number. It's the biggest experience there is, but it's a very small number. So I think you'd opt for over treatment to try and get as high a cure rate as possible. Yeah,
but no, I agree. I don't know how many of these are seen around the country, just generally, in terms of volume. But yes, expect this is probably
definitely not surgery for the occasionalist, I would have thought.
Absolutely.
Should we go to
great, yeah, because that comes on to the next one, which is another series from Professor Mundy on another complex problem, which is symphyseal fistula after treatment for prostate cancer. And again, I think probably we're seeing more similarly because of extra treatments, salvage treatments for prostate cancer, use of brachy and radiotherapy, as well as salvage surgery. And so they report here a large series, again, for this kind of complex procedure of 40 patients who underwent symphyseal fistula repair after radiotherapy. And again, this highlight that in a center doing lots of these, you can get really good success rates with surgical treatment. But it's interesting that actually a lot were managed conservatively, just with the catheter drainage and antibiotics and improved. But the other really interesting thing is that all of them had some form of, however innocuous, some form of urethral instrumentation, which kind of precipitated the fistula. So I think that's something that's really, which I hadn't fully expected, that even just doing a dilatation or something could precipitate in these patients this kind of complication.
I don't think we can say though to prostate cancer surgeons and general and urologists around the UK, whatever you do, don't instrument the urethra in men who've had radical prostatectomy and radiotherapy for prostate cancer for fear of causing this, because if they're obstructed, they're obstructed. It would be good. I mean, maybe you need to be very cautious and not do a urethrotomy.
I think probably just exactly.
Yeah, it might be better to try a gentle dilatation with the Cook dilators. Do you use the Cook dilators? Yeah,
in fact, that's generally all we use.
And this may be the case if you're finding it difficult to get them into your unit, to say, you know, we've got much less of a chance. Well, that's my impression, but there's no data of charging this. They talk about failures, and they talk about the failures not being in terms of, they say all of the patients had a significant reduction of pain because this is a really painful condition. Most of them were wet after they had their definitive surgery or their diversion, and the ones who were dry seemed to be dry because of artificial urinary sphincter, but we couldn't find out how many had artificial sphincter.
So exactly. So we did contact Simon. Actually, he mentioned that he did reply saying that there were 2 patients who had an AUS after a salvage prostatectomy, one after a redo vesicourethral anastomosis. But they thought that actually the AUSs may have compounded the fistula by acting as a kind of obstruction, distal obstruction. And so they managed, I think one was just by deactivating the AUS, the other was AUS removal.
Can I just say, I've just got a phone call come through from Tony Mundy. It's like, we could put him on.
Is he watching this?
No, we won't.
But no, I mean, the results seem like, because I agree with you, we had a couple we've seen like this, and they're in a severe pain. So at least pain relief wise, it seems like really good outcomes.
So I think concluding from this, be very gentle if you're doing outflow obstruction endoscopic surgery after that particular combination of radiotherapy and surgery. And if they do get a urosymphyseal fistula, refer to an expert and divert the urinary stream. Yeah, fantastic. Next one, please. Right, so this is a series from Wiltshire, Melissa Davis's group, and she's basically looked at all her non-mesh stress incontinence surgeries from, I think it was 2016 to 2019. So I think this is her BAUS database entry data. And she has done 80 they've done 80 cases in that time. 80% of them are primary stress incontinence. She hasn't given exact numbers. They're divided between bulking injections, presumably with Bulkamid, as that's the most commonly used injection agent nowadays, autologous fascial sling and cold post suspension, and they point to the median that 86% of the cases were performed as a day case, which makes me think that 86% of cases were probably bulking agents. We send our fascial slings and colpose suspensions home after 2 days. I think the laparoscopic colpos from Urogyne go home after a 1-night stay. So it would be, do you do any of your bigger ops as day cases?
No, to be honest, both of these, the colpos and the fascial slings, tend to stay for at least 1 or 2 just because of the bit of pain from the phalansteal. But some of the American series report day case fascial slings.
But they've got their definition of day case. They've often got a hotel or a hostel on a hospital site where they stay overnight and then get checked out the next morning. So it's all related to, it's interesting that how you manage your patients post-operatively is dictated by the financial aspects of your healthcare systems. And in Germany, no one's a day case because they get paid a lot more if they stay in for 2 days. But I think these are very good results. 86% of patients, or 80% plus of patients, are significantly improved afterwards. Pad usage went down from 3.3 to 1 per day, and it shows that you can get very good results for primary incontinence in good hands. Yeah,
absolutely agree. It looks like the colpose suspensions probably got the best results.
Would be nice if we had more of a breakdown of their outcomes and indications. But I think it's encouraging that UK standards are very good. Next.
The next one. The next one's kind of similar theme. Again, it's about mesh-free surgery, and actually this group from India presented quite a nice study actually on a small number of women, 30 women with primary stress incontinence, treated with an autologous fascial sling, but that was put in through the transobturator route. And so it's primary stress incontinence. They've excluded patients with intrinsic sphincter deficiency. But their results, in terms of their report continence, I assume means completely dry of 100% at short-term follow-up. They haven't really given the exact definition of how they define continence. Is it completely dry or a safety pad? But either way, I mean, 100% success rate is good.
That's good. It's the best results in the world. I can only aspire to that. What about you?
Yeah, I've never had 100%. No, sadly not. But I like the way they describe the technique. And it does involve 2 passages of the trocar. So I've not done this technique before.
Although I know that the Cumberledge Review has basically said that once mesh centres are up and running, retropubic midurethral tapes are an option for women with special counselling. They've kind of pointed away from doing obturator techniques because of the groin pain. There are still a few situations in which I think it's important to stay out of the pelvis and to avoid a synthetic tape. The patient who's had radiotherapy and has an obliterated pelvis would spring to mind. So I think this kind of natural tissue obturator technique does have its niche usage, but there's no way you can avoid the double passage of the needle.
Yeah, and that's why I agree with you. It'd be good to know in all of these studies on stress incontinence, it would be good for people to report on pain as well, because there's no reports here on groin pain. It would be interesting to know whether you still get a similar level of groin pain as you would with mesh.
And we also know from the Bowes audit database that there was more pain, persistent pain at 3 to 6 months in colpose suspensions, rectus fascial slings, and Blazonec AUSs than in the more minor retropubic tapes, obturator tapes. So I think it's very important for people to keep prospective data on chronic post-operative pain, because it's probably a phenomena that's there for all surgery that we need to be warning people around.
Yeah, agree. One thing I did like about this, by the way, is just they do report on outcomes of female sexual function as well with FSFI. So not a lot of studies do that, which is quite nice to see that. It just helps counselling, I guess, that you can say to women that it can also improve their sexual function.
Yeah, definitely. Should we go to the next? Thanks. So this is another one continuing with the autologous midurethral sling. This is a retropubic group, and it's from the Eastbourne group, James Moore's group, and they've looked at long-term follow-up in a cohort of 31 patients, and they've got a 7-year median follow-up, and it basically shows that there's a significant improvement in their outcomes in terms of patient satisfaction, quality of life, patient global impression, and continence. About 80% of them feel that their life has been greatly improved, and about 12% of them thought that their life had been worsened long term, and they'd accepted not just pure stress incontinence, they'd accepted mixed incontinence with urodynamically proven overactivity causing wetness. So I think this is nice long-term honest results that you feel that would be replicated, and very good standard, and it allows us to tell women what might happen long term. You know, it's not 100%, but there's a significant chance that they're going to become much drier or dry, and there's a significant chance that their life is going to be significantly improved. And the other interesting thing is that only one of them needed to self-catheterize long term. So they've obviously been putting in them relatively loose, and that was also encouraging to put them in relatively loose.
Yeah, I agree. The other good thing is they report the pelvic pain outcomes. So like you said, it was interesting to see that, you know, still 10% would have long-term pelvic pain.
Yeah.
So good for counselling, even fascial slings, where I guess a lot of people assume you don't really get any pain.
And I think with the fact that mesh for continence has definitely gone out of favour in the United Kingdom with patients as well, there is definitely a resurgence of the autologous mini slings through the small incisions. Are you doing a lot of those?
None, just I'm doing the same technique as this, really, the sling on a string.
Sling on a string, yeah, which is, you know, they're home within a day or two. It's not as immediate in terms of with the midurethral tape, they were home the same day or the very following morning, but it seems to be a fairly good alternative. Yeah. Looking at James's results in particular. Thank you.
Yeah, great. Okay, should we go to the next one? So this is a change of theme now. So this is a study from you, Tamsin, of your experience of a large number. So it's a review of 100 patients who have had urethral diverticulectomy with a minimum of 1 year follow-up. There's a big data set and lots of data. And essentially the key finding, this is looking specifically at the incontinence outcomes. And so essentially the rate of stress incontinence preoperatively is 25%, and de novo stress incontinence is 23%. But actually there's significant improvement afterwards with either conservative management or then 89% success rates with further surgery. So I think it's really impressive outcomes for a group with kind of complex diverticulum. So I think the question I had really was, because I do this obviously same technique as you, because you trained me, but I think the Marsh's fat pad is one thing that obviously I know you do in all patients. And I guess what I've started to do in those with relatively simple diverticulum where you can get good closure, I've not always used a fat pad. But do you think the fat pad itself may help to improve continence? Because a lot of those who had pre-op stress incontinence didn't have stress incontinence afterwards based on this series as well. So I wonder whether the fat pad itself acts as a kind of buttress or something.
So it may act as a natural tissue sling, because you do pull it down and put it over the midpoint of the urethra where you've taken off the diverticulum. But I think it also gives you an additional layer of well-vascularized tissue that maybe allows the sphincter and healing to be improved. It definitely gives you a nice vascular plane for if you need to go in and perform additional stress incontinence surgery. And there's relatively little, there's not zero, but there's relatively little morbidity related to the fat pad.
And in these stressing, in these patients who have surgery afterwards, do you typically start with bulking, or is it a fascial sling for most?
Well, I offer them everything. I went through a phase where I wasn't keen on offering intraurethral bulking because we'd operated on the urethra, but actually we offer them everything nowadays. Initially, the cohort is mainly divided between obturator tape, because I thought we should stay out of the pelvis and we might damage the fat pad by putting a TVT through, and autologous sling we've moved to latterly. And I think the autologous sling is the way to go if they want a definitive procedure, but there does appear to be more avoiding dysfunction than with the obturator synthetic tape.
It'd be good to know, actually, if you do any other future follow-ups on this, if there's any way to predict, because I know you don't do stress incontinence surgery at the same time.
No.
But I mean, again, in the States, some people talk about doing that.
So Eric Rovner's, we've combined with Eric Rovner in the States to put together our series to look at outcomes, and his outcomes are pretty similar to ours in terms of the end results of continence. And so you can come at it in different aspects. But there was, I think it was something like 65% of women who had a simultaneous autologous sling were dry afterwards, but 35% were. And then if you've used your autologous sling, you're then on to the next stage. So what are you going to do? You can try and do a little bit of bulking, or you can try an artificial sphincter, but by that stage you've had a urethra and a bladder-neck that have been operated on twice. So
I suppose if there's a group you could identify where you say, okay, beforehand you've got your severity is this bad, or your diverticulum is this complex, and so your chance of having post-op SUI that's going to need treatment is 80%, then at least I guess in that specific group you could say, all right, well, we can offer it at the same time.
But so few women then went on to have 19 cases had surgery for their incontinence out of 122, that if we could, if the holy grail is risk stratification, but I'd still be loath to do it because so many don't need it.
Yeah.
Okay, thanks.
Nice.
Go to the next.
Yeah.
Thank you. Now this is a nice series from the Inman and Chapel group in Sheffield, looking at the outcomes of genitourinary fistula repair. Now they don't specify, so I'm presuming that these are vesicovaginal and urethrovaginal, and maybe even some uterovaginal fistula, not just all vesicovaginal fistula. And they've got 95 patients that they followed for at least 12 months. And I think the interesting things are an excellent primary cure rate, and the fact that about 35% of them had already had one failed repair at another centre. So I think that fistula surgery definitely should be concentrated in areas of significant expertise, because there's less than 100 in England each year. And obviously these centres such as this one can get excellent outcomes. And the other interesting thing to me was they predominantly do an abdominal approach, 73%. They predominantly use mental flaps. When they do a vaginal repair, they're using Marsh's flaps. So I agree with them on that. But they're talking about quite a significant number of women developing stress incontinence afterwards, about 22 of them, so about 24%. And that isn't something, and I've looked at the long-term outcomes of our women who've had vaginal repair of a vesicovaginal fistula that I've noticed. And I just wonder if they're reporting, because it's a mixed group, the urethrovaginal fistulas with the vesicovaginal. What do you think? Yeah,
I think it sounds like that, doesn't it? Because they're kind of grouped all into one. So it'd be good to know the breakdown of the urethro and vesicovaginal fistulas.
If you're going to repair a urethrovaginal fistula, especially maybe one that's after a mid-urethral tape, then you're almost expecting stress incontinence afterwards. Whereas if you're doing a vaginal repair of a vesicovaginal fistula, I would be completely surprised if they developed stress incontinence afterwards, unless they were going to develop it because they'd had a hysterectomy and it was going to mass stress incontinence.
Yeah, I agree. The other interesting thing is on I've not seen this really, but they've had 2 patients who they say recurred late, 2 years down the line. So do you think that's a recurrence, or do you think that's just a new fistula that's formed?
I don't know. I'd be interested in their thoughts. I mean, very occasionally you see a patient who's been operated on many years ago who suddenly seems to apparently spontaneously develop a fistula. So maybe it's related to lack of blood supply. Mm-hmm. Yeah. Should we move on?
Yeah. So we're going to the last one, which again is from you, Tamsin, and again, a really nice abstract. So this is looking at the learning curve for VVF repair. Actually, something that's really interesting because, you know, people always ask you how many cases you need to have done or to be able to do generally per year to get good at this. So I think this is really nice. So you've looked at your 100 patients over the last, since 2004, I think.
It's my learning curve because I'm old, yeah.
And so you've shown that essentially your outcomes have been really good anyway, but you're saying that about 75 cases is probably the typical number you need to get up to a level where you can repair most vaginally, well, all of them that are suitable for it, and you can get 100% success rate. Now, something that's really good to know that 75 is a number, but these are all done by you. There's not any other.
Yeah, they're all mine.
And have you changed your technique at all over the time, or has it essentially been pretty much the same approach, same technique?
Well, as I've got more experience, I've gone more towards obviously vaginal repair because it's less of an insult for the women. They're often involved in litigation, and I think a smaller operation kind of calms it down a bit as well. So I think that helps because it doesn't seem such a big insult to have a vaginal repair rather than abdominal repair. No, I've just got braver and able to, you know, when you're starting off, you should tackle the easier ones vaginally, or have someone, grandma, with you to help you do it. Yeah. But
so that's what I was going to ask, because they say
the same technique.
Yeah, and it's similar. I was going to ask you, similar with your paper, and even if say even Chris Chappell's paper before, obviously the volume of fistula generally in the country is not massive.
No.
They've reported they're 95 over however many years, and there's this series. But so if the number's 75, how can how can people get those numbers up?
I think you have to. You either go somewhere where fistula is much more prevalent. Having said that, obstetric fistula in low resource healthcare settings are different to the type of fistula you see post-operatively. They're probably more challenging, but we just have to see. But I think you have to go to a centre that does a lot in order to get that experience. Sadly, we need to, in order to get good results for these women, they do need to be concentrated in centres doing a significant number each year. Yeah,
agree. Well, it was very nice abstract.
So I think we can end our session there and say that it shows very encouraging outcomes from UK practice, a nice autologous technique from India, but it makes you feel that there's I don't feel bad about getting older and maybe needing to see one of you as I get older.
That's very nice. I agree. It's been a really nice session. There are lots of good posts.
Fantastic. Thank you.
Thanks.